I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. And I'm excited to have with us today Will Fawcett, who's a medical student, and we're excited to have you on board today. Will, thanks for joining us.
Thanks for having me, Dr. Aguila.
So, Will, why don't you tell us a little bit about yourself?
Yeah, I'm a second year transitioning into third year next month, medical student at Oklahoma State College of Osteopathic Medicine. Found Dr. Aguila via LinkedIn and social media through some of his posts, and found his ideas about direct care and about the current state of the medical system very interesting and engaging. And then I've kind of just been following along and been a big supporter of what you're doing, and shedding light on another side of medicine that I think all medical students and residents should be aware of as an option for a future training pathway. And that led us to this conversation today.
Awesome. So let me start off the conversation with this question for you, Will. And again, we can go in whatever direction you want. But here's my question for you. What is it about direct care that got your attention?
Yeah, I think for me, it's the constant narrative about burnout in medicine and about how overworked, underpaid, or the administrative burden that physicians feel in just about every specialty that I see online. And I started to, question, look, I'm on this path. Physicians are posting, making it seem like this isn't what it's all cracked up to be. And if that's the case, what have we gotten ourselves into? And is there another way? So for me, that's when I started looking and seeing not everyone can be upset about this. Maybe there's somebody that's doing something different that I'm not aware of. And, I ran into your post, and you've been such a big advocate for the direct care model, and it's led me down a rabbit hole to several other people, and it's really given me hope for the type of physician and practice in life that I want to build with my patients alongside me. So that's kind of where the ball got rolling for me.
Awesome. And so what did you discover along the way?
I discovered that, like most things in life, you have more control than maybe it seems to be on the outside. Taking care of patients is not can't only happen inside a hospital, and can't only happen inside of the insurance model that most people seem to operate in here, at least here in the US. Just because that's the predominant model doesn't mean it needs to be the only way. And not only does it need to be the only way, it might not even be the best way. Perhaps we need outside the box thinkers like yourself that have kind of driven the conversation to make us reevaluate those things. It's kind of led me to really, really think about that, and what exactly is it that I want to get out of medicine at the end of the day.
Sure. So if you'll recall, Will, when I asked you to be a guest on our podcast, it was because I recognized that you represent our target audience. I mean, you fall squarely into that demographic, and there are a lot of people who are listening to or watching this podcast who have like a bazillion questions, some of which maybe we've addressed in our previous episodes. But if you've watched any of our episodes, you know that for the most part, I don't do a whole lot of talking. I do a lot of asking, and then I let the guests talk. And obviously, we could do a lot of that here today too. But I also wanted to give you an opportunity to pose those questions that you or your classmates have developed over the last couple of years that you've been a medical student. Because I know, correct me if I'm wrong, but you've started talking to some of your classmates about this stuff, and I would imagine some of them are very receptive, and some of them are skeptical, and some of them might even be hostile.
Yeah, absolutely. I think we're all aware of the challenges that are ahead of us in medical training. And I think everyone is starting to look around and ask questions about what are our options moving forward. And So yeah, I have brought this up to them and it's been really cool to see the ideas that have come. And I'd be happy to ask you some of the questions that I've jotted down over these last 2 years that I have for you. It's a conglomerate of my own thoughts and those of my classmates.
Well, that
Um,
sounds great. Let's do it.
the first one that I have is what, for you specifically, Dr. Aguila, what was the problem that you were trying to solve when you moved to direct care?
Oh, that's a great question right there. So for me, wow, my seat just dropped. Uh, for me, I didn't realize I could lower my seat. So for me, the reason that the problem that I was trying to solve, the question I was trying to answer, was how can we be more fair to our patients? How can I, as a physician, be more fair to my patients and take good care of my practice and good care of my family? Because what I got tired of patients coming to me. So I just to give you the background here, I used to work for a hospital. I was a specialty surgeon, subspecialty surgeon working in a hospital system. And it would routinely happen at least once a week and sometimes multiple times a week. Some patient would come into the office really, really pissed off at me. And since this is a podcast, I could say pissed off. Yeah, yeah, but I mean, somebody came in, patients would routinely come in there pissed off at me. Like, doc, if I had known that this was going to cost this much, I wouldn't have done it. If I had known that it was going to cost that much, I would have asked you, can we try something else? Or, how come it costs this much? Where do you get off charging this kind of money? Well, first of all, my first answer was I didn't charge that money. I don't have any control over how much money gets charged. I don't have any control over, what the cost of any particular procedure or visit or whatever is. I just work here, and I got tired of taking the blame for the decisions of other people. And I said, you know what? If I'm going to take the blame for something, it should be for something that I did, right? Somebody wants to be angry at me, well, then they should be angry at me for something that I'm actually responsible for. And so I realized the best way for me to address that was to open up my own practice. And it was around that time that I discovered the Free Market Medical Association. And then I realized, this is the abbreviated version, but I realized that the insurance model in most cases is actually hurting the patient. It hurts the patients, it hurts the doctors, it hurts everybody that's delivering the care. And I said, you know what? I can't do that. I mean, that's totally antithetical to what I was trying to achieve. I was trying to provide better care more affordably to my patients with greater transparency so that they can make better decisions. We talk in medicine about, particularly in surgery, we talk to patients about the risks, the benefits, and the alternatives of the care we're going to provide. Well, there aren't just medical risks. There are also financial risks, benefits, and alternatives. And we should be having those conversations as well. But within the insurance model, I wasn't able to do that. And it wasn't fair to my patients, and it wasn't fair to me.
Well said. And kind of piggybacking off that, I'm assuming your appointment times now have increased. You're able to spend as much time as you want. How have you noticed that this shift in care has changed outcomes for you? Have you noticed an improvement in outcomes or in at least patient satisfaction?
For sure. For sure. Thank you for asking that question. So I remember a time when it was not unusual for me to see over 100 patients in a day. Okay. I mean, that's crazy. 100
A
patients.
hundred?
Yeah. So let's say I work, just to make the math easy, right? So let's say it's a 10-hour day and I don't take a lunch break, right? If it's 100 patients in a 10-hour day, well, that's 10 patients an hour. That's 6 minutes per patient, right? And with the electronic medical record systems, I mean, study after study has demonstrated that physicians on average spend over 60% of their time in a visit doing documentation. So out of that 60-minute visit, that's 3 minutes, 3.6 minutes. So let's say 3.5 minutes. That means 2.5 minutes that I actually get to spend with the patients. Okay. I was like, holy crap. Now, these days, an initial consultation with one of my patients, we book 2 hours. Okay.
Holy
And our
smokes.
follow-up visits, I book an hour. And patients are shocked. They come in, they're like, doc, I know you're busy. I'm like, sir, ma'am, we set aside this time for you. We blocked this much time. You have until such and such a time to ask whatever questions you want for us to do whatever procedures you want. I mean, when I had those 6-minute visits with my patients, I mean, what I ended up doing was I ended up saying, okay, I'm going to look in your, somebody would come in, they have a sore throat, or let's say they had a problem with their voice. This is a great example. Okay. They had a problem with their voice. Well, I know that patient probably needs, at the very least, a flexible laryngoscopy, or maybe even video stroboscopy. Well, how long does that take? That takes at least 10 minutes to get everything set up and to actually do the procedure. Well, guess what? Can I take care of that patient today? No, come back next month when our next opening is, so that I can do the video stroboscopy. Now, maybe I could do the video stroboscopy that day. I'm like, okay, come back for a third visit so that I can go over the results of the video stroboscopy, right? Today, if I were doing video stroboscopy, I could do all that in one visit, but since my practice is focused primarily on pain, the patient comes in and let's say they need diagnostic nerve blocks. I could do the nerve blocks all in the same visit, and we can, here's one of the things I love. Okay. So if somebody comes in, let's say with post-herpetic neuralgia, chronic pain after shingles, unlike what you've been taught in medical school, it doesn't just involve one nerve. It's rare that it involves just one nerve, right? Classic teaching is it involves one nerve. And that's not been my experience. And so in a conventional model, what would you do? You'd come in for your visit. I'd say, okay, it looks like it's probably the intercostal nerves at the T2, T3, and T4 levels. So I'd see you for your first visit. The second visit, we would do the nerve blocks, right? And then the third visit, you'd come back and tell me the results of your nerve blocks. But what if you only got partial relief? Well, that means we need to do more nerve blocks in order to figure out, okay, well, what did we miss in that previous visit? So now we've got a fourth visit, right, to do the additional nerve blocks, and a fifth visit in order to talk about that. Well, guess what? I do all of that in one visit. So you come in, I say, oh, well, it sounds like we need to block this nerve. We block that nerve. You say, well, this is better, but that's not. Okay, well, let's block the next one. Oh, and this is better, but that's not. Okay, we just keep going, process of elimination, until we map out all the areas that we need to take care of. And then we can come up with a plan, and then I can present to you the options, and then you make a decision, all in one visit, all one time, instead of 5 visits spread out over 3 months.
It's fantastic.
Yeah.
Going off that too, what is the patients that you are seeing benefit the most from this type of model of care? Because some of us, as in medical school, we're trying to decide where we want to go. Some of us make decisions based on the patient population that we like to work with.
Sure.
And I don't think that's a bad thing at all. What would you say you've seen? What kinds of patients have had the most success from your direct care?
Sure. So, as we've discussed before offline, you have, there's a direct primary care model and there's a direct specialty care model, right? Direct primary care, usually you have a subscription model. It's kind of like going into an all-you-can-eat buffet, right? You pay this much and you get to be there for a certain amount of time. So like you pay $100 for a 1-month membership. You go in as many times as you want, get as much care as you need. Okay. It's all covered. And then you have direct specialty care, which, there are a few exceptions. There are some direct specialty care practices that use a subscription model, but for the most part, particularly those that are procedure based, you get a menu, like going into a restaurant, like, okay, well, a neurectomy costs this much, and a tonsillectomy costs this much, and a breast augmentation costs this much, and you decide. I'm not saying that those are all alternatives for the same problem. Okay, I'm just
right.
Here's your menu, right? And
Yeah.
And then you get to make an informed decision. You're like, okay, well, how much is my problem bothering me? Does it bother me enough to spend that much money, right? People think, oh, well, the direct care doesn't exist. Of course it does. LASIK, that's direct care. Breast augmentation or any other kind of cosmetic surgery, that's direct care. IVF, that's direct care. There's all kinds of stuff out there that's direct care. I was talking to a pathologist the other day, and he owns the largest pathology practice in the state of Nebraska. He does all of the autopsies for the state of Nebraska. Insurance doesn't cover autopsies. That's direct care, right? And so, it exists. It's been in existence for a long time. As a matter of fact, direct care is the way medicine has been practiced for thousands of years successfully all around the globe. It's only been in the last 60 or 70 years that we've tried this crazy experiment called health insurance in the United States. And I think we can all agree that it doesn't work particularly well, with very few exceptions. But having said that, getting back to your question about outcomes and which patient populations seem to work the best. So I've heard people ask me, before. They're like, well, doc, I mean, you're a subspecialty surgeon. Of course it's going to work for you because people come from all over the place to see you. But that's not going to work for me. And they're right. I've had patients now from all 50 states, and I think we're up to 32 or 33 foreign countries we've had patients come to see us from. Okay. So they're right that patients come, but they come because they see value, right?
Mm.
And so the people will say, well, I'm not specialized like that. I can't do that, right? But then you have the direct primary care doctors. Well, they're about as generalized as you get, right? And I've heard people say to the direct primary care doctors, well, you can only do that because you provide every little bit little bit of everything in medicine, but I'm a specialist. I can't do that. Well, clearly it works in direct primary care and it works in direct specialty care. Most people fall somewhere in between, right? And so it works. For me in particular, in my practice, the patients that seem to benefit the most are the patients that make up almost all of my practice, which are people who have chronic pain. And the majority of them come to see me because, number one, they've run out of options. Number two, the thing that I hear from them all the time is they're shocked that we spend as much time with them as we do. And I tell them, how else am I supposed to figure out what's going on with you if I don't get the big picture? And the only way I can get that big picture is to hear the whole story and to examine you and to do whatever other tests that we need to do in order to confirm that diagnosis, right? So in our practice, those patients, they're just blown away. They're like, I can't believe that you just spent 2 hours with me. But that's what we do. That's who we are. But that's not to say that the direct care model doesn't apply in a similar fashion to people who are in primary care. I mean, I have a number of friends who are direct primary care docs, and they're like, you know what? I had this patient who joined my practice, and she's got uncontrolled diabetes. Well, not anymore. Why? Because I got to spend the time educating her, coaching her, helping her figure out what she can do to better take care of herself, because we have the time. And, I can text with her and I can email her and I can give her phone calls. I can give her tips and so forth and so on in order to help manage the problem, help get her in better shape, and they get better outcomes. There was a study that was done here in Nebraska. I can't remember if they've already finished it or if I was just looking at the preliminary data, but they were looking at direct primary care outcomes, specifically as it related to diabetes versus conventional primary care. And what they discovered in this study, comparing side by side, apples to apples, was that patients got better outcomes and it was more affordable through the direct care model.
That's awesome. And I think a big hiccup that when I brought this up to classmates, they kind of would push back and say, well, here's our biggest complaint. How do you take care of the people that maybe can't afford it, but that really need the help? Under the current system, not saying that, the hospitals aren't, they send bills to people regardless of their insurance status sometimes and things like that. So it's not like we have an awesome system necessarily taking care of those that are underprivileged and underserved. But what are some ways that you've been able to take care of some of those vulnerable populations as a direct care surgeon?
Sure. I'm glad you asked that. There are as many ways to do that as there are physicians that provide that care. In my practice, we offer the M25 program, and I know you and I have talked about that before. It's a mechanism by which patients can volunteer at a nonprofit of their choice that we collaborate with. If it's somebody we don't already collaborate with, we can develop a relationship with them. But they volunteer at a nonprofit, and then some type of charity organization. And then once they volunteered enough hours, then I'll do the surgery for them. Whatever surgery it is that they need. Now, what does that do? I mean, study after study has demonstrated that patients who have invested in their outcomes get better outcomes. But why would we choose a model in which we've taken away that really great tool for them, the one that helps improve their outcomes? So what happens when they volunteer in these situations? Number one, they get the care that they needed. Number two, they didn't end up with crushing medical debt. Number three, the charity that they served has benefited from their work. Number four, the community that the charity serves has benefited from their work. Number five, that patient has gotten to see, oh, well, that person's worse off than I am. Yeah, I'm in a really crappy situation, but that person's even worse off. And I helped that person. well, maybe I'm not in as bad a shape as I thought I was. And what does that do for their self-esteem? What does that do for their dignity and their self-worth when they realize even in their own misery, they can help somebody else. And in so doing, they get to help themselves. I mean, that's beautiful. And then on top of all of that, all the members of my team have the satisfaction of knowing that we can do uh, that we can do charitable work right in our own backyards. We don't have to go all the way across the world to Timbuktu, get on a plane, be away from our families for weeks or months at a time in order to help people. I mean, there's people in our own neighborhoods that need help, that are financially disadvantaged. And we can do that right here. Who wins? Everybody. Who loses? Nobody. Now, when you look at other practices, one of the benefits that I've seen when I've had this conversation with other doctors, whether the direct primary doctors or direct specialty care doctors, is that because they're not constrained by the insurance model, nobody tells them what they can or cannot charge, right? So like, for instance, if you participate in the Medicare model, right? And let's say your patient doesn't have supplemental insurance, but they got Medicare, right? And you say, you know what, I feel really bad for you. I'm just going to waive that. Well, you can't do that. You cannot do that, because what are you doing? You're breaking the rules of Medicare. And if you do that, I mean, there are certain hoops you have to jump through in order to be able to do that. But if you just do it willy-nilly, say, you know what, don't worry about paying the rest of that fee. Guess what? You just broke the rules. Now, if you do that with, one of the commercial carriers, they're going to fine you. And they're going to take that money out of the next amount of money they're supposed to pay you. But Medicare is the government, and it's part of the government. It's a government-run organization. So guess what? You didn't just break the rules. You broke the law. And in the process of trying to help somebody because you feel bad about, being able, not being able to take care of them because they can't afford the care, you could be going to jail. But you know what? When you work in a direct care model, I could say, you know what? I get it. You can't afford that today. We're going to call it good. I have that option. Somebody who works in Medicare and is taking care of a Medicare beneficiary, they don't have that option.
That's awesome. That's awesome to hear. I really love that program that you mentioned, and I've never heard that brought up as an option, the M25 program, and I think that's something that everyone should be aware of.
Yep.
That's a really cool way to do it.
M25program.com if you want to know more about it.
That's awesome. Another pushback that I got from colleagues, and all these are completely valid concerns, is some of them mention like, hey, I got into medicine. I just want to go to work. I want to take care of my patients and I want to go home. When I clock out, I want everything to be left at work, or they just talked about how they don't want to deal with overhead. They don't want to deal with payroll and the business side that might accompany something like direct care. Walk me through what it looks like to run not only your direct care, but in general, what direct cares run, how lean do they run, how much time outside of the clinic do you really have to spend to get this going? And is that something that kind of bothered you, or is it just something you learn on the job? And yeah,
that's a great question. So before I answer that question directly, let me start with this. All those things need to be done, right? Payroll has to happen. The lights need to be kept on, right? The bills need to be paid. We gotta pay for the heating. We gotta pay for the electricity. We gotta pay for the plumber. We gotta pay the rent. All those things need to happen. And if I don't do it, somebody else will, right? I'll either do it myself or I'll hire somebody else to do it. Now, your colleagues may say, "But I'm not hiring somebody else to do it. The hospital hires or whoever hires it." But who's paying for that? I am, right? Because the revenue that I generate is being used by somebody else to decide who gets to stay and work here and do that job and who doesn't. When you're the business owner, you get to decide who works for you and how many people are working for you, okay? When you're an employee and you're stuck with an employee that you really don't like, who's running your front desk or who's answering your phones or who's dealing with the insurance companies, and you're like, why did you do that? I didn't want it done that way. Well, guess what? You don't have the authority to tell them to do it this way or that way because you're not the one running the business. So when you walk out the door and say, I just want to be a clock puncher, I just want to be a widget maker, you're leaving all those responsibilities to somebody else. And in so doing, you're giving up your autonomy. You're giving up your ability to make those decisions. Now, if you want to just bend over and take it up the tailpipe every single time somebody does something in a way that doesn't serve you or your patients well, maybe that's a good fit for you, okay? But I would argue that taking care of the patient means that you have to be responsible for the whole process. Okay, you owe it to that patient. So I'll give you a concrete example. For me as a surgeon, right? When I'm in the operating room, I'm responsible for every single thing that happens in the operating room, right? So if the patient bleeds to death, God forbid, okay, I've never had that happen, but let's say that happens, that's on me, right? Okay, because I'm the surgeon. I'm supposed to be controlling all of this. If the person who's doing my anesthesia breaks that patient's tooth, who's the patient going to remember? Is that patient going to remember who the anesthesiologist, the nurse anesthetist was? No. That patient's going to associate that broken tooth with me. And every time they look in the mirror and they see the broken tooth, they're going to think of my name, my face, my practice. Okay. Let's say, the surgical tech, let's say we're doing an endoscopic procedure and the surgical tech leaves the endoscope on the drape and the drape lights on fire. I've seen this happen before. Okay. The drape lights on fire and the patient ends up with a burn. Does the patient care that the surgical tech did that? No. Because I was the one that was responsible for making everything in that room happen the way that it's supposed to happen. Well, guess what? When the patient comes in to your practice for a visit, they're going to hold you responsible for everything that happens, whether it's the insurance billing, whether it's the smell of the room, whether it's how dirty the floor is. They're going to hold you responsible, whether you like it or not. Okay? And they're going to blame you, just like they blamed me for years. I'm like, if you're going to blame me for something, then blame me for something that I actually have control over. Okay. Now, what does it do when I say, well, that's not my fault? Now it looks like I'm just passing the buck. What does that do for the relationship that I have with that patient? What does it do for the trust that I have for that patient? Because ultimately that patient's going to ask, oh, so the hospital really screwed this up. So I shouldn't trust the hospital, but I should trust you. But you chose to work for or with this hospital. Well, what does that say about your judgment for choosing to work with or for that hospital, knowing that they keep screwing these things up? The patient ultimately is going to hold you responsible on some level. Well, if they're going to hold you responsible anyway, then why not take responsibility? Right? Now, let's get to the nitty-gritty of your question, right? What does it look like? How lean do things need to be? So when I first started out my practice, I thought I was really innovative and I was going to be lean and I was going to do things better than everybody else. And I started out with nine full-time employees and four contractors, 1099 contractors. Okay. And guess what I found out? I was way too many people. My overhead was eating up all our revenue and I was trying to save people money, and I was trying to take good care of my family at the same time. That wasn't happening. Today, it's me and one other person. And I have, one part-time employee who works about 20 hours a month, maybe 10 hours a month. And I have a contractor who does all my marketing. It is lean, it is mean, and we get great outcomes. Now, some people will say, well, but then you're doing everything all the time. Well, guess what? You learn how to do things efficiently, and you also cut out a bunch of the BS that you don't have to worry about anymore. So, like, for instance, you haven't gotten into this yet, but there are certain metrics that Medicare requires us to track if we're participating in Medicare, like MIPS. Okay, I don't even know what MIPS stands for, but it's all these different metrics, and then you have to supply these reports. Well, guess what? You got to pay somebody to do that. And then when you put together your note, you got to think, okay, did I include all the MIPS criteria? Well, does that make any difference in terms of your clinical decision making? Does it actually lead to a better outcome for the patient for me to track all this MIPS stuff? No, it's just how I make sure that Medicare doesn't take money back from me. But since I don't deal with Medicare, I don't have to worry about that, right? So what goes into my note? The stuff that I want to know and the stuff that I want anybody else who's going to read my note, what I want them to know. That's it. I don't have a whole bunch of extra BS that is totally irrelevant. Like, I get medical records from other doctors' offices because I'm a subspecialist, right? And I will often get these notes that are 20 or 30 pages long, and there's 3 paragraphs in there that are actually relevant. And all the rest are all these insurance criteria. You got to pay for an expensive medical record system in order to track all that stuff. You have to spend time putting all that stuff in because you become a data entry specialist. Oh, no. I hire somebody else to do that for me. Okay. You got to pay that person, right? That comes out of the money that you generate. Does that person generate any revenue for you? Nope, not at all. Okay. So we run pretty lean and we pass the savings on to the patients.
That's awesome. Kind of pushing back on your point, do you think there's anybody that would not be a good fit? Maybe it's a specialty, or maybe it's a type of person that you think you would advise, just say, well, maybe this isn't for you, or are you a proponent of everyone could make it work if they wanted in any specialty?
So the one specialty that we've had difficulty trying to figure out, and I'm sure somebody's going to figure out eventually, but right now it's still one that we wrestle with. It's emergency medicine, right? Um, and I don't have a good solution for that. But I'm sure somebody will come up with a good solution for that at some point. I'm pretty confident about that because, as we talked about previously, direct care has been around for thousands of years all around the world. It's been practiced successfully and affordably, and patients get great outcomes. And it's been in existence here in the United States, even through all this stuff going on with insurance. The people that I think would probably not be a good fit are people who want to be widget makers, people who want to punch a clock. Okay. Now, it used to be back in 19 Forgotten when I was a medical student, okay, people like that were really discouraged from going into medicine because, it was an investment of yourself to become a physician. And I think because of the way the insurance model in conjunction with the hospital systems, the way they've morphed the healthcare system, we have a disproportionately large number of people now who are just who want to punch a clock. They want to be widget makers. Are there roles that that are shift work roles like critical care and emergency medicine? Yeah, there are. But even within those fields, the people historically, the people that went into those fields, they're like, look, I want to be a good doctor, as opposed to I just want a paycheck doing something that I like to do.
Totally fair.
I know that's kind of
You know,
harsh, but I think that's the reality.
no, and sometimes that's it's easy just to say it how it is.
Huh.
In 2026, I don't know how different it is when you started direct care compared to today, but some of my classmates were asking, well, what about the labs and the imaging and things like that? When you're running this lean, how are you making contracts with other labs or imaging centers to get discounts for your patients? And if so, what if you're in a situation where you don't have those private businesses willing to make those deals with you? Do you have to live in an area where you have those types of relationships? How does that go about?
That's great. So, as far as labs and imaging go, that's actually the easiest question to answer. Number
Mm,
one, don't send your patients to the hospital. Send them to an independent lab, send them to an independent freestanding imaging center, because those companies want direct, they want direct care because they roll the dice whenever they've got an insurance patient. They're like, I don't know if I'm going to get paid. So I'm going to bill a whole lot of money and hope I get paid something. But they don't know if they're going to get paid. Whereas when you roll in the door and you want an MRI and you say, I'm going to pay cash, guess what? They get their money the day that the service happens. And I mean, for me as a business owner, I'd much rather know I'm going to get paid, right? I mean, all of us want to know we're going to get paid for the work that we do, and generally speaking, independent freestanding imaging centers and independent labs, they're happy to give you the cash price. As a matter of fact, most of them have one ready to go already. Stay
that's
away from the
awesome.
hospitals. The hospitals aren't much interested in that because it requires somebody to say, okay, well, we need to do it this way or we need to do it that way, depending on the situation. They don't want to make it all one size fits none.
What would you say has been your biggest challenge in recruiting patients when you first started the marketing aspect? How did you go about getting a new patient population?
The key to getting a patient population is to be a good doctor.
Hmm.
Be really good at what you do. No, you got to be honest with yourself. You got to say, okay, what am I good at? What am I great at? What am I just mediocre at? Okay. And then double down on the things that you're awesome at. You got to figure out what am I better at than all of my colleagues. Okay. So maybe my patients like to see me because I'm so good looking. Okay. I mean, I'm sure that's a factor in my patient population, but I'm sure it's not the primary one. Okay. But you got to ask yourself, you got to be really honest. Okay. What am I better at than everybody else? For some doctors, it's like, okay, I spend lots of time with my patients and the patients really love that. And so that's what they want. And patients recognize that value. Okay. You have to figure out, what value do I offer better than anybody else? And then you double down on that. That's the hardest part. The hardest part is recognizing that you have value and then embracing that. Because we've been taught in medicine that in order for us to be compassionate, we have to do everything for free. Okay. But that devalues you as a physician. It devalues me as a physician. And what does that lead to? Burnout. I'm doing all this work and nobody cares. Right? The first thing you have to do is love yourself. You have to value yourself. Then you have to figure out, okay, what does that value look like? And then say to your patients, I don't know what your problem is worth. Nobody knows what your problem is worth except you. But what I do know is what my time and my expertise are worth. And this is how much it costs. You decide whether or not that's what you want to do. I mean, really, you're restoring autonomy to the patients. Whereas in an insurance model, you take a lot of it away because you're putting all the decision-making on the shoulders of the insurance company.
Wow. We'll end on this. My last question for you. What what advice do you have for medical students like myself as we get ready for rotations, going into residency, and then eventually make career decisions on where we want to go? We have student loan burdens that, the interest rates seem to be increasing. The burden, as average, I think around $250,000. I think some people might immediately discount, like, hey, I can't, maybe direct care is awesome, but I can't get into it because, I need a high paying job right off the bat to pay off these loans. There's so many factors that might go into dissuading us from going into this. So what advice would you give to us as we try to lead, hopefully, the next generation of physicians and maybe the next generation of direct care physicians?
Sure. I'd love to be able to tell you there's a quick and easy answer to that. And there kind of is, but it's a little bit involved. Number one, become a member of the Free Market Medical Association. Okay. I'm the Nebraska chapter leader for the Nebraska chapter of the Free Market Medical Association. And so, we're very much involved in helping educate people on free market medicine. So become a member of the Free Market Medical Association. Number two, come to our annual conference here in Nebraska. We're having the Nebraska chapter of the Free Market Medical Association. We're having our annual conference on the 21st of August here in Omaha. Okay, join us here. If you're a medical student and you can't figure out how to pay for it, the Benjamin Rush Institute will likely be very interested in getting you here and helping finance it, maybe even make it free for you. So look them up, the Benjamin Rush Institute. But even if you can't do any of those things, the most important thing, find yourself a mentor, somebody who's already doing this, who's already doing direct care medicine, and have that person take you under his or her wing and learn from that person, because then you can ask these questions and you could see how this plays out in the real world. You could see how it plays out in a practical sense and start to ask the questions that you need to ask and start to implement some of the strategies that you want to implement so that you can get from here to there. Okay. There are lots of options when it comes to student loans. You just need to be willing to think outside the box. I mean, for those that are so inclined, you can join the military. I did. The Air Force paid my way through medical school, and then they paid for my ENT residency. They paid for my aerospace medicine training. They paid for my plastic surgery residency, and they paid for my peripheral nerve surgery fellowship. Okay. I mean, and I didn't go to some, Timbuktu institutions. I mean, I did my head and neck surgery training in Mount Sinai. I did my plastic surgery training at Hopkins. That's, those are good institutions, so that's an option. The Public Health Service is another option. The Indian Health Service is another option. Those are a whole bunch of different scholarship programs, and there are a lot of communities that are willing to do loan forgiveness if you agree to work for them for a particular period of time. There are a lot of hospital systems and other places like that that'll say, or private practices and group practices say, hey, you'll come work for us. If you assign a contract that says you'll work for us for 3 years, we'll pay off your loans. Or whatever, there are all kinds of scenarios like that. And then along those lines, it's really tempting when you graduate from residency and you're making minus 50 or minus $100,000 a year, right? And you get this paycheck for 50 grand. You're like, holy crap, I just got $150,000 a year raise. I'm going to go spend this money. Don't. Okay. And then when you graduate from residency and your income quintuples, you're tempted to go out and get the big house and get the big car and, get the 2 dogs and whatever else. Don't do it. When you graduate from residency, continue to live like a resident until you don't have any more debt. Okay. When you don't have any more debt, guess what? You're free. Okay. As it says in Proverbs, the debtor is slave to the lender. Right? And who wants to be a slave? So it's time for us to wrap up. Will, do you have any final parting thoughts or any particular questions before we tie all this up?
No, I just say I appreciate the work that you do, and I really think what the direct care movement is offering is a really, really good solution to the physician burnout rates that we're seeing across all specialties. And I really hope that this gets to the right people so that they know there's another option out there for them. And this might be exactly what they need and what they envisioned when they got into medicine.
That'd be awesome. Well, let me offer this to you and to your classmates, since there seems to be some buzz generating down there in your neck of the woods. If there's interest in having me come and do a talk in whatever setting, I mean, whether it's just a whole bunch of us sitting around having pizza together or whether we want to do something a little more formal, let me know and we'll see what we can coordinate.
I think that'd be awesome. I think we have a business leaders in medicine club. I think you'd be an awesome speaker for that club to kind of give them the, okay, I'll put you in contact then with our new club leader.
All right. Awesome. I look forward
Perfect.
to it. Anything else you want to add, Will?
No, I'm good.
All right. Well, thank you, Will, for joining us. It was exciting having you on the Direct Care Movement podcast. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.